Okay, and welcome everybody to the vision screening training. I have a new lap desk, so maybe this will keep me center frame a little bit better. We'll see how it goes. This is the yellow card as opposed to the green card. It's really similar. Name 2025, my mistake on the hearing screening one, today's date. Be sure you fill this in except for this part. Your name, your complete address, you want to use the legal address, even if it's not close by, because they will send changes to the law, that sort of thing, into here. And the other is still audiology student. So you have plenty of introductions to me. Let me pause this for a minute. Okay, back to recording. I realized might be easier to do if I were wearing my glasses and could actually see. So I guess my connection to this is I have very poor vision. So what is a vision screening? Well, much like a hearing screening, it's a simple non-diagnostic it's not even an evaluation. It's a simple non-diagnostic procedure that tells you whether or not you need to move to full diagnostic testing to assess if they have an actual vision problem. And the reason it's so very important is that 80% of learning is visual. And again, much like hearing, catching it early will have a significant and profound effect on a child's life. So what we're trying to do is determine if a child's vision falls within the normal range, which is 20/20. So what we're trying to answer is do they need assessment or not? Yes, no. And then we want to identify those children, refer them to their primary care providers, and follow up. You'll see that this mirrors the hearing screening program significantly. What we're going to discuss today is what's essential about vision, and so we need to screen it, the different types of vision problems, the specific procedures used in a vision screening, the recording and referral procedures, and then online reporting. So, in the chat, discuss, have you had any personal experiences with vision-related issues? Obviously, I have. Now, the fun thing about this, if anything about vision issues can be fun, is that I didn't start wearing glasses. I didn't get my first pair of glasses until I was in the summer between my freshman and sophomore year in high school. I had vision problems before that. And probably about mid-junior high, I realized I had problems, but I never did anything about it. And in fact, actively actively worked to pass the screening procedures. So the way they would do it where I went to school is everybody would line up and it was the same chart for everybody. So when I first started doing it, I didn't realize I was paying attention to what everybody else was saying and that I was memorizing what the letters were. And then when I realized, hey, glasses were a real thing, I did that purposefully. And then finally, in the summer between my freshman and sophomore year of high school, I was at a Youth Opportunities Unlimited camp, and it was a very different screening procedure, and they caught me, and for my first real tax-paying job, I had to buy my own glasses. Not fun. But I skated through, and looking back, there were plenty of places where somebody should have been able to catch me. So next we're going to talk about the screening schedule and the requirements. So who must be screened? Any 4-year-olds by September 1st, any kindergartners, any other first-time entrants 4 years through 12th grade, and that should be done within 120 days of admission. And then grades 1st, 3rd, 5th, and 7th, anytime within the school year, but preferably within the first part of the school year. Why? So you don't waste time, so the kid doesn't miss educational opportunities. Now, they also recommend that transfer students without current vision screening records, students returning from an absence resulting from a communicable disease, students referred by teachers, parents, or others, and children who repeat a grade and who have not been screened within the last year. So, Texas only has 2 charts now. It used to be 3, but now it is only 2 different charts. So you're recording distance acuity for each eye individual using one of the following: the Sloan letter chart or the HOTV chart. And the crowded version is preferred but not required. So what is acuity? Acuity is the sharpness of vision that is measured and recorded using an internationally recognized 2-figured indicator such as 20/20. So what are the recording and reporting requirements? Well, the facilities may use either the M60 form, which is on page 53 in the appendix of your vision manual, or you can create your own form that has the same information. Kind of familiar to the hearing screening one, right? And then you submit the summary of results online at the website between January 15th and June 30th of each year. And the requirements for recording is the full name of the child, the birth date or age of the child, the date of the screen, the name of the screener printed and signed, the type of screening, any signs and symptoms of a vision problem, whether the child was wearing corrective lenses during screening, the acuity for each eye and or pass-fail, and pass-fail is for automated screening devices, plus the results of any other screening. Now, we won't be working with automated screening today. That's not a thing we're going to do. Those are expensive and we just don't have funding for that. So question, why is it important to screen children at a young age? Chat in the chat. So now let's talk about establishing a screening program. Ideal screening procedures follow the American Association for Pediatric Ophthalmology and Strabismus guidelines, and they are moving towards the automated and stereo optic systems. It'll be interesting to see over the years how far that goes because it's, like I said earlier, quite a bit more expensive. Our objectives are to identify a kid that needs further assessment, to refer to the primary care provider for a diagnostic evaluation, to provide educational consideration and recommendations to maximize learning potential, and tracking and follow-up for all of the referrals for evaluation to maintain the program's effectiveness, right? If you don't follow up and find out do they have a problem or not, you have failed. As a screener, our objectives are multifold, again, like the hearing screening one. We need to recognize signs and symptoms of vision problems. We need to make an appropriate screening environment. We need to determine which screening chart to use. We need to train the child to respond accurately to the symbols on the chart. We need to pre-test to determine the appropriateness of the chart selection. We need to demonstrate proper screening and record-keeping procedures. We need to determine if they've passed or they failed. We need to determine if we need to rescreen and set up an appropriate time frame rescreen. And we need to monitor the referral status. And of course, we need to understand what the follow-up procedures are for those who fail to screen, and we need to understand the online reporting procedure. Now, again, unless you end up in a school district where you're in charge of this, you won't, for right now, be doing the online reporting. So the training will help you to establish a screening program that meets all of the aforementioned objectives and goals. I will be providing you a physical book that you will keep for ever and ever, amen, that would help have all the materials needed except for the actual charts and measuring tools, that sort of thing. So tell me about what the characteristics of an effective screening program are, um, and chat about that. Now we're going to talk about the eye and the sight process. We will be playing videos because of how I'm recording this. I can't figure out how to take my face off of the screen while the videos are on, so I'm going to just cover that up and mute my mic so it doesn't compete. So, sight and development. Well, sight development involves the brain's ability to receive and interpret the messages sent by the eye. And many authorities in the field don't really believe that eyesight's fully developed until they're 7 or 8 years old. So that's why there's different requirements. Much like hearing, you're not screening at absolutely normal. You're kind of in that gray between area. But the big deal about it is binocular vision, seeing with both eyes. So let's work on understanding how the development of the sight process puts together and how we use binocular vision to see. So what is binocular vision? Well, it's the ability to use both eyes at the same time to focus on the same object and to combine the two images into a single image. And that's what provides good depth perception, right? So much like having two ears is what's needed to understand speech and noise and to have directionality, right? You need two eyes to see how far things are. So let's look at the eye, which is a really cool thing. You have the cornea on the outside, and it's kind of flexed out and above the iris, above like we're looking up at the sky. It's on the outside, and then so the cornea is on the outside, and then there's kind of some space, and we've got the iris and the lens underneath, and the ciliary bodies, and the sclera. We're used to seeing the sclera like right there, but it actually goes all the way in. Sorry for my sneezing pause. So the sclera goes kind of all the way around. And then there's the fovea and the optic disc back here and an optic nerve with the blood vessels. So it's pretty complex. I don't think it's as interesting as an ear, but there's a lot going on here. And what's happening is the light is reflecting from all objects, and that it enters through the eye, through the cornea, and light travels through the pupil. And let me pull up my notes because this is not my best subject. And then the pupil widens or narrows according to how bright the object in space is, and the light travels through the lens. And the lens is like a camera that focuses the eye on the shape on the retina. And to focus, that lens is trying to change its shape, so it puts the picture directly on the retina back there. And that's known as accommodation, when the muscles move to move the lens. And we want it to be focused right here on the fovea centralis, not over here in the optic disc, which is the blind spot. And then from there, the optic nerve receives the information about the light and then sends it to the brain for meaningful interpretation. In the best case, perfect scenario.
We must first examine how vision works. In order for one to see, a light source is required. Without light, everything is black. The light emits particles called photons, which bounce off solid objects in all directions before eventually reaching the eye. In order to see well, the tissue that they go through must be transparent. First, the cornea, located at the front of the eye. Then, the crystalline lens behind the pupil. Then, the vitreous body in the middle of the eye. Finally, they reach the retina, the eye's photographic plate, stopping at the retinal pigment epithelium, where they set off nerve pulses. These pulses are directed towards the optic nerve, and then the optic pathways, before arriving at the occipital brain where the image is formed. This process is what enables us to take in the world around us.
So that was pretty exciting, wasn't it? So let's talk more about accommodation, because that's kind of one of the important parts. So the ciliary muscles kind of contract or lengthen, and it pulls this closer or further apart to redirect where the light is in the back of the eye. So accommodation is merely the adjustment of the lens. And then binocular vision occurs when both eyes automatically adjust so that the image being viewed falls into the same part of each retina, and then the brain says, oh, those match, I can see. That's fusion. When we don't have fusion, we get blurry vision. So you might have experienced this by having a head injury that caused it, or taking central nervous system depressants, which could cause your eyes to not be able to, because the brain is what manages all of this. Now, suppression is what happens when one eye is being naughty, let's say, and so consistently the images do not fall on the same parts of the retina. You have double vision, and the brain eventually is like, nah, I'm going to turn that off. That's too much. We're just not going to do. And so it literally suppresses an eye. And that's the thing that we want to screen for, because that is an effect of amblyopia, or rather, suppression results in the development of amblyopia. I don't really care for how they line this out. It's kind of backwards from the way my brain works, which is if you have an eye that's not doing what it's supposed to, then the brain can't fuse it. If the brain doesn't fuse it, it will suppress it, which then leads to the eye wandering off, amblyopia. It's ambling around. So suppression is when the image of an object for one eye is not perceived, Amblyopia is a dimness of vision or reduced acuity in one eye. It's not usually correctable by a lens. And of course, visual acuity is the relative ability of the visual organ to resolve the details. And it's like 20/20 or 20/30 or 20/40 or 20/50 or 20/60 or 20/70, 20/80. 20/100 is considered legally blind. So what is the ultimate goal of good vision? You can chat about this. I didn't put it, but the ultimate goal is to be able to see clearly at appropriate near and far distances with fused binocular vision so that we have adequate depth perception. So we're going to go over this next part, which is farsightedness, nearsightedness, astigmatism, and the signs and symptoms of a vision problem. So the next thing we're going to talk about is refractive errors. And a refractive error is a condition in which light rays cannot be brought to a single focus on the retina because of problems with the cornea or the lens. Examples of refractive errors are farsightedness or hyperopia. They can see really well far usually, but not so well near, which is myopia. And then astigmatism, which is an unequal refraction within the same eye. So I have one eye that is really, really nearsighted, but only a little bit astigmatism. And the other eye, it's not so nearsighted, but it has a huge amount of astigmatism. And so when you see me moving and twisting and tilting my head and switching eyes, it's because my eyes are a mess. I am so ready for the AI overlords to take over and release me from this defective meat suit I'm in. But in the meantime, I have an excellent optometrist and I see the best I can with the glasses I can get. So farsightedness is when the eye does not focus well on the nearby objects. It's corrected with a convex or a plus lens. My sister is actually farsightedness, and she laughed at this because she says that's not really how it works at all, because it's not that clear of a delineation where it's just like boom blurry and then boom clear. There's gradations through the process. Nearsightedness occurs when the eye does not focus well on distant objects. It's corrected with a concave or a minus lens. To me, these close kids look pretty blurry too. I don't have a good answer to how accurate this is for nearsighted because, as I said, I also have pretty significant astigmatism and also a lot of asymmetry between my eyes. And the astigmatism occurs when the cornea or the lens in the eye curves more in one area of the eye than another. Rather than like a cup, it's kind of a wiggly, jiggly sort of mess. And it results in a blurred image and poor visual acuity because the reflected image of an object focuses on different points in the retina, and it's corrected with a cylindrical lens. And it really, how you see it depends on how your eye is curved. I don't see this way, and is it because my astigmatism's not shaped that way or because I'm also nearsighted? I don't know. But if you go on Facebook, one of the viral shares is astigmatism and traffic lights with those little, with the lines kind of going like this, or starburst patterns. So for me, if I close my eyes, I actually get different. Close both my eyes. No, I'm not in my car driving with both eyes closed. But if I'm parked and I look out and I close one eye, one of them is more of the starbursty pattern and the other one is more of a straight line. And that's how my astigmatisms are. The other vision problems we're going to be talking with are strabismus, which is the two eyes not being equally aligned, and then amblyopia, which is that wandering, walking eye. So in strabismus, one or both eyes may turn out, up, or down. It's, why did my brain just delete that? But it's like wall-eyed or cross-eyed are the more common ones. And a lot of babies kind of start out that way, but it's developmental and it usually straightens out. If it doesn't, though, you need to do something about it because eventually the brain's going to ignore the visual input from the misaligned eye, and that leads to that amblyopia or lazy eye in the eye. And there's 6 external muscles called the extraocular muscles that control the eye position and movement. And for normal binocular vision, the position and control and functioning of them must be coordinated pretty perfectly. And any problems could be from the muscles themselves, the nerve, or from the brain. Genetics does seem to play a role, though. If one parent or the other has strabismus, the children are at a greater risk of developing it as well. So amblyopia results when the brain and the eye do not work together properly, and it causes one eye to turn off, as I've said multiple times and in this presentation, because Department of State Health Services in Texas really wants you to know. It is the most common cause of vision impairment in children. It can improve significantly if it's detected and treated early, like before age 7. I mean, the sooner the better. But if you don't catch it, it's going to persist into adulthood. Now, signs and symptoms. Observing for signs and symptoms of a vision problem is part of every vision screen. Even if the distance acuity screening test or any other test for visual function is passed, if you observe any signs or symptoms of a vision difficulty, it is a reason to refer to the child for follow-up to their provider. Just like hearing screening, if a kid has found a way to game the screen, you still need to refer them if you notice that there's a problem. Okay, on to the next one. So here's the signs and symptoms that you need to look for during the screen. You're looking for crossed eyes, you're looking for red or watery eyes, you're looking for squinting, you're looking for them to try and get out of the cover to go around. You're looking for them to try and cheat out and use their good eye. And you're looking for them to lean in and strain, sort of thing. Those are all signs and symptoms that even if they pass, that you should send them out for. And there's a checklist in your manual. Okay, so what should you do if a child who exhibits signs or symptoms of a vision problem passes his or her screening? Write it in the chat, obviously, talk about that. But the answer is refer them. So now we're going to talk about the 2 different charts. Sorry, I accidentally bumped it. I didn't mean to move so. We're going to talk about the 2 different charts. One is the HOTV chart. It is just those 4 letters. It is not for children who know all the alphabet. It is a matching game. You're literally if they can say HOTV, you need to move to the letter chart. And you would have a little matchy pad for them to point to indicate which one it is. And then the other one's the Sloan letter chart. So here is an example of the HOTV crowded version. It is usually for children 5 and under. If you've got kids who are already readers at that age, though, you're going to need to use the Sloan one. If you've got developmentally delayed kids who don't know all their letters and aren't starting to read, you would use this for an older kid too. And then it's only available in a 10-foot distance chart, so you should always check to see. Now, if you go in close, you've got 1050, 1040, which is equivalent to 2010. And right here you have one that says actual size 10-foot equivalent. That's your indicator that you need to be 10 foot from the chart. The Sloan letter chart is generally for children age 6 and older, or any child who can accurately verbalize and identify the alphabet letters, and there may be a 10 or a 20-foot chart. It needs to be a sans serif, no serif chart. It can't have any colors, it can't be fancy, it can't be engaging, it needs to be this very, very boring chart. Just very boring. So what is the appropriate chart to use with a 6-year-old who can correctly identify alphabet letters 100% of the time? Next, we're going to talk about preparing the screening environment. I think the next one's a video.
As a vision screener, you have the opportunity to help children who may have a vision problem get the help they need. Since you'll be screening children in a range of ages and abilities, we'll demonstrate how to prepare children and your environment for a successful screening. Module 1. Preparing the screening environment. When preparing for a screening, you'll want to make sure you have the following items: steel measuring tape, masking tape, footprints that indicate where a child should stand. These are available in the appendix of this manual. Occluders. Examples of occluders are heavy paper with rounded corners, paper cups, or commercially produced paddle-like devices. Plain butcher paper to provide an uncluttered background. Flexible lamps with 60-watt frosted bulbs to light the chart. Pointers. These can be purchased or made from a dowel, small rod, or chopstick. Avoid using a pen or your finger as a pointer. Copies of the screening record forms. These can be found in the appendix of your vision screening manual. Visual acuity charts. The charts you use will depend on the age of child you are screening that day. Cover cards to cover areas of the chart for greater ease in screening. Make sure you have a good room in which to conduct the screenings. An appropriate room is quiet, free from disturbances, and accessible for people with disabilities. The wall where you hang the eye charts should be free of clutter and have normal light without shadows or glare. The room should be at least 2 feet longer than the required screening distance for the chart you are using. If you are unsure what distance to measure, check the top of the vision chart. Using a metal tape measure, measure the appropriate distances from the chart and place the footprints. Ideally, you will have a screening team of certified screeners who can help you set up for a screening. However, one certified screener may train and direct the activities of any uncertified screening assistants.
Okay, so occluders, we tend to use disposable ones, and I am kind of country, kind of low class. I tend to use styrofoam cups, or oddly enough, coffee filters. If you like fold a coffee filter into the quarters, you've kind of got a nice little rounded cover that works pretty well actually. So next we're going to talk about how to set up a successful screening, and there's a bunch of videos in this section, I believe, too. But first, step 1, assemble the following supplies: steel measuring tape, masking tape, etc., all the things that were in the video. 2, position the eye chart on the wall so that the 2030 or 2040 line, also known as the passing line, is at the eye level of the average sized child you will screen, but also be prepared to move it up or down in case you've got a really tall kid or a really short kid. It's very important, though, that you know what the passing line is for the age of children. So 2040 is for kids all right, so I'm not entirely sure why that switched over when I was trying to draw, but 2040 is for 4-year-olds, and 2030 is for 5-year-olds. Now, what's normal vision? Normal vision is 20/20, but again, we have just like with hearing screening, we have imperfect situations with people who have relatively small amounts of training compared to a diagnostic test, and kids who are being rushed through the system. So we're trying to make the screening program cost effective so that we don't refer too many kids, right? So then step 3, we're going to measure the distance indicated on the top, mark it, ask the child to stand so that the back of their feet or the back of their heels is on that mark. And then if they're seated, align the back of the child's head with the mark. Nice little picture of what they suggest you use. A light to shine on it so it's good and bright, no lights from the sides, the distance, and a wall. You need to determine the assistants and their positions and what the roles are, and we'll discuss that next. And it depends on how many people you have. The important thing to remember is that you alone cannot be a screener. So for practicing today, we will be using your supervisor as one of the assistants, and we will be using the 2-person team process. And I think that tends to be the more common way to do it. But if you have more people, you can keep track of things better. So how do you know where the child should stand for a screening? It's literally on the chart. Always double check that though. Next is the roles of the screening team. So there is like all those checklists and there's diagrams and explanations in your manual. Now remember, ideally you have 3 people, but you need at least 1 certified person and at least 1 other person, and you need to train them ahead of time. So the practice or the starting line is 1 line above the passing line. So for children 4 and younger, that means they need to start at the 2050 line. And then for 5 and older, they need to start at the 2040 line. Now, it can be tempting to stop at their passing line, but you do not stop at the passing line. You go down as far as you can because there's rules about what's a pass or fail depending on the age of the child. And to pass a given line, they must identify 1 more than half of the symbols on the line, and the visual acuity score, like the 2030, 2040, is always the last line that is read correctly or passed. And passing again means 1 more than half of the symbols on the line. Pro tip, if they've already said or accurately identified 1 more than half of the line, you don't have to finish the line, you stop and move to the next one. Now, member 1 is supposed to stand near the child. They greet the child, they get the child's name and their age, they position them at the appropriate distance from the chart, and they hold the occluder for the child. And then they signal to the other team member when it's time to display the next symbol or line on there. You can do that by like giving them signals like and you don't want to like say, oh no, you don't want to tell the kid they didn't get it correct. So like good can be everything is correct. I mean, good can be that the symbol was correct, and great could be not. And the other person does need to know whether it's correct or incorrect, because they need to know whether they need to keep going on the line, or whether they need to move to another line, or whether it's time to stop. Member 2, if you have a 3-person team, member 2 is to stand near the chart or be seated near the chart. They determine practice and passing lines according to the child's age. They use cover cards as needed. They point using a pointer, and they listen to the screener signals to determine what line to display, what symbol to display, and when to repeat a line. And if you have a member 3, they should be seated at a table facing the child, midway between the chart and the child. And they're the ones who do the writing and drawing and recording signs and symptoms, and observes the behavior of the child during the screening, and make sure he or she does not peek around the occluder. And they're noting screenings and referrals on the appropriate form. So if you have all of those people, member 1's here, member 3 is here, and member 2 is down by the end of the chart. If you do not have anyone else to help you, is it okay to have a child hold his or her own occluder? Chat about this in the video chat. There's only one right answer, but tell me if any of you have had a screen when you were a kid that you held your own occluder, because I can tell you I did. Next, let's talk about preparing the child.
Module 2. Preparing children to be screened. Before you screen any child for vision problems, make sure they understand how to read the eye chart you'll be using. Young children or children with special needs may need extra help or special accommodation during screening.
The HLTV chart is recommended for children 5 and under, and the Sloan letter chart is appropriate for children 6 and older who know the alphabet.
Before any of the 3 charts can be used, the child must understand how to play the matching game, respond with 100% accuracy, and be able to transfer the game to the chart. Module 2A. Screening children with the HOTV chart. First, we'll demonstrate how to screen children using the HOTV chart. This chart is appropriate for children who do not know their alphabet or cannot grasp directional concepts due to language, intellectual, or physical limitations. To prepare a child for screening with the HOTV chart, instruct only one child at a time. Teach them how to match the symbols H, O, T, and V. Tell the child to point to the symbol on the panel that looks like the symbol on the card. Display each training flashcard one at a time at increasing distances, while the child matches them on the response panel. Avoid establishing a pattern of response in the child. Remember that they must answer with 100% accuracy. Then have the child practice the matching game as you point to symbols on the chart. Tell the child to point to the symbol on the panel that looks like the symbol on the chart to make sure they are able to transfer the game to the chart. Practice until the child shows they can stand or sit 10 feet from the chart and correctly match each symbol indicated on the response panel. Review the symbols before the screening takes place. The child may need additional training to help transfer the matching skill to the screening chart.
So, if you noticed or wondered why they were talking about it's for children who can't do directions, they didn't actually update these videos when they took out the tumbling E. Now, talk about like your experiences. Did you ever do the tumbling E sort of thing where you had to do that? I hated that one. So, chat about tumbling E. All right.
Module 2C. Screening children with the Sloan Letter Chart. If you'll be using a letter chart, establish that the child knows the alphabet and have them read the letters on the practice line with both eyes open before you conduct a screening. If the child cannot identify letters accurately, use an alternate approved chart for screening. The American Association for Pediatric Ophthalmology and Strabismus now recommends screening with Sloan letter charts rather than the traditional Snellen letter charts. In order to be in compliance with national guidelines, please screen with the Sloan chart whenever possible.
So, before you screen with that HOTV, they actually have to practice. And so much like when I'm giving my instructions for hearing screening, I make it a game. I'm like, okay, we're going to play the matching game today. And what I need you to do is when I point to a letter, I need you to, as fast as possible, point to the letter on your pad and show Miss whoever there is on that side. And the thing about the HOTV one is if it's held up at an angle, you can often see through and see which direction it is. It kind of depends on your light source, though. Was checking to make sure I turned my mic back on. Now, if the child cannot be trained using that, they won't play, that sort of thing, you would need to attempt to retrain like pretty close. Very young or new students may need some time. But if they still cannot train, you don't just wait until they can be trained, you refer them to a specialist, their primary care doctor or whatever. So, for children being screened using the HOTV chart, should you review the training right before the screening takes place, or is this considered cheating? I want y'all to talk about what is the purpose of what we're doing and why reviewing things is often not cheating. You'll experience the same thing in audio and in audiometry, especially with SRT. There are things where knowledge of the test material and familiarity with the test material is integral to the results. And if they're not familiar with it, then you're not getting accurate results. So familiarization is actually important in multiple places. So next we're going to talk about the screening procedures. The goals of our distance acuity screen is to obtain distance acuity for each eye individually. So you're not going to say bilaterally. You're not going to talk about that because you're not doing it together. And then you need to determine whether the child passes or fails the screen. Note, ideally you have 3 members. We've already talked about that, but at least one needs to be a certified screener. It's very important to note that if the child has prescribed glasses or contact lenses, they must wear them at the time of the screening. Rescreens and referrals on this are based on the acuities of acuities with the correction. So unlike hearing aids and cochlear implants, you do test with the glasses.
Module 3, Screening Procedures. We have covered how to prepare your screening environment and how to ensure children are trained for different screening charts. Now you are ready to conduct a screening. Greet the child and ask their name and age. Have them stand with the back of their heels at the 10-foot mark, facing the chart. If the child is seated, align the back of their head with the mark. If the child has been prescribed glasses or contact lenses, they must wear them at the time of the screening. Determine the beginning line based on the child's age. Use the 20/50 line for children ages 4 and younger, and the 20/40 line for children ages 5 and older. Next, place the linear cover card, if used, on the chart to expose the entire beginning line, or use the isolator cover card to expose a single symbol on the line. Have the child read the beginning line using both eyes to ensure that they can screen successfully using the chart. Be sure to have an assistant available to hold the occluder during screening. Never let a child hold the occluder themselves. The child may never use their hand as an occluder. Begin the screening by covering the child's left eye with the occluder. but tell them to keep both eyes open. Screen each eye one at a time, starting with the right eye. Place the tip of the pointer directly below each symbol to be read, refraining from touching the symbol. Ask the child to identify the symbols when you point to them. For younger children, point to symbols on each line from left to right. As long as the child can identify at least one more than half of the symbols on each line, continue screening to the 20/20 line. If a child cannot read the beginning line, 20/40 or 20/50 line, move toward the top of the chart until you find a line he or she can pass. Then move down the chart until the child does not pass a line or until they read the 20/20 line. Remember, to pass a line, the child must identify one more than half of the symbols on the line. Communicate the child's visual acuity score to a team member who is acting as the observer recorder. The visual acuity score is always the last line that is read correctly. The observer recorder records the visual acuity score for the right eye and all signs and symptoms of possible vision problems. If the observer recorder notices any accommodation behaviors, such as squinting, they should note this and try to get the child to stop these types of behaviors during the screening. Screen the left eye, repeating the same process. As a vision screener, you should always respond to the child in a positive manner. Using words such as good or fine after each response will speed up the screening, especially for very young children. Take some time now to practice these different tests with your instructor. The Vision Screening Manual will guide you through the same steps that were just demonstrated in this video.
Okay, so remember, peeking around the occluder results in more children passing the screen who would normally fail. This is probably the biggest fault or failure of screening programs. It's definitely the most common screening error. So you need to be sure the occluder blocks all vision in the eye that it covers. So how do you know if a child has passed the screening? Well, for children 4 years of age and under, the passing line is the 20/40 line, and they must read at least one more than half. For children 5 years and older, they must read the 20/30 and get 4 out of the 6 symbols at that level. But also for 4 years old, they can't have an asymmetry between the eyes. The best line in the one eye can't be 20/40 and the best line in the other can't be 20/20. If there's that 20 point difference, then it's also a failure. Now let's talk about some of these optional screenings. Some of them, we tend to think of them as less than optional and more as mandatory. The automated screening one, that's optional. We don't have the equipment. But the Hirschberg corneal light reflex test, that's a little less optional, and the cover-uncover test we would prefer to see done as well. And the stereo acuity one, not so much. So automated vision screenings, it's just an automated system they kind of put their heads on. Only if you're trained on that should you use this. We don't work on this. There's some facts about that. You can go ahead and read them, but it is an option available through the age of 5. Photo screenings, automated, etc., etc. It really can't determine exactly how well the child's vision acuity is developed. It can be recommended for people who literally cannot participate due to language or other barriers and do not respond well to being trained with a more interactive sort of screen. The muscle balance tests are used to determine whether the eyes are aligned correctly so that binocular vision is normal. They're optional by law, but they're especially recommended for kindergarten, first and third grades. Why? Because we're trying to prevent that whole suppression and amblyopia thing, and before the age of 7 is ideal. The Hirschberg corneal light reflex test is appropriate for all age levels beginning at 6 months of age, and it enables you to detect a constant muscle imbalance or misalignment, which is a type of strabismus, because you're looking to see what the light is on both of the pupil and see if it matches up. And if you see something that you're like, you want to have other people correct you. If you're just not sure, like, double check. That is not cheating. That is actually what you're supposed to do. So the cover-uncover test is checking for strabismus or muscle imbalance too, and it's for less constant imbalances. And you check that by covering and uncovering the individual eyes, and you need to be able to recognize when the muscles are imbalanced. Normally, we would have everybody look at everybody's eyes to kind of see. Obviously, in the time of COVID, that is not going to be happening. If you're watching this in a time that's not COVID, oh great, I'm glad we're out of COVID. Please let us have non-COVID times. All right.
Module 4, Optional Muscle Balance Tests. Muscle balance testing helps determine whether the eyes are aligned correctly. When one eye does not respond adequately and cannot look directly at an object, the individual has a muscle imbalance. Muscle balance tests can be performed on children of any age, even as young as 6 months. While these tests are encouraged by the Department of State Health Services, they are not required. Module 4A, Hirschberg Corneal Light Reflex Test. First, we'll demonstrate the Hirschberg Corneal Light Reflex Test, which detects muscle imbalance or misalignment of the eyes. All you'll need to conduct this test is a pen light and a solid, interesting object for fixation. Begin by positioning the child so that the pen light is held about 12 inches away from the child's eyes. You can use the length of your forearm for a reference when estimating how far away the light should be from the child. Align your face with the child's and hold the pen light in front of your nose. Do not hold the light at an angle or move it back and forth while looking to see where the light falls. Instruct the child to look toward the light or at your nose. If you are screening a young child, move the light back and forth to make it an object of attraction and fixation, and then return to a fixed position for observation. Observe the reflection of the pen light in the pupils of both eyes. It should be centered or equally centered slightly toward the nose for the child to pass the test. If the reflection does not appear to be centered or positioned slightly toward the nose at the same distance in each pupil, the child fails the test. If the child fails, rescreen immediately. If they fail a second time, refer them to their primary care provider. Module 4B, Cover and Uncover Test. Another optional test used to screen for strabismus or muscle imbalance is the Cover and Uncover Test. To perform this test, you'll need a solid, interesting object of fixation and an occluder. First, align your eyes with the child's eyes. You may need to seat young children upright in an adult's lap. Hold the target object about a foot away from the child's eyes, directly in front of them. Permit the child to fixate their eyes on the target object for 2 to 3 seconds. Ask the child about the target object to make sure that they are focused on the object. Cover the right eye with the occluder while watching the left eye for any shifting. Leave the right eye covered 2 to 3 seconds. Remove the cover while watching the right eye for any shifting. Allow 2 to 3 seconds for both eyes to fixate on the target object again. For young children, try manipulating or changing the target object to maintain attention. Cover the left eye with the occluder while watching the right eye for any shifting. Leave covered for 2 to 3 seconds. Remove the cover while watching the left eye for any shifting. Allow 2 to 3 seconds for both eyes to fixate on the target object again. Repeat this procedure several times to confirm observations. Next, place another target object 10 to 20 feet away and at the child's eye level. Repeat the cover-uncover procedure. When performing this screening, you should look for shifting in either eye. It's important to note, however, that the most recently uncovered eye deserves primary consideration. Take some time now to practice these different tests with your instructor. The Vision Screening Manual will guide you through the same steps that were just demonstrated in this video, and it will explain how to make referrals and report your screening results.
So, fun and excitement. Now let's talk a little bit about stereo acuity screening. It's supposed to look for different issues: near point acuity, far point acuity, phoria, fusion, color perception, and lateral coordination. But again, we don't do those. So what do the muscle balance tests help identify? Chat about this topic and chat about any experiences or any people you've known or your experiences with this. For instance, my best friend's daughter had it and she was delayed for quite a bit because remember, it's a little bit developmental. And so she ended up not having to have anything go on, but it was like touch and go for about 6 months. And then you need to record your results and make referrals, right? So let's talk about that. Passing criteria for children age 4 years and younger is 20/40 or better in each eye and less than 2 line difference between the acuities in 2 eyes. That's the second failure of programs besides the peaking outside of the occluder, is they'll stop for 4-year-olds at 20/40. And the way the state catches that is because all the 4-year-olds have acuities of 20/40 and none of them have acuities of 20/20 or 20/30, or 5-year-olds are all 20/30. You need to go as far as you can. Again, for 5 years and older, it is 20/30, but you should try to get to 20/20 if you can. Photo screening is literal pass-fail, and the machine tells you. So how do you rescreen, or rather, when do you rescreen? Well, if they fail the screening of either or both eyes and there are no signs or symptoms of a vision problem, you need to rescreen within approximately 2 to 3 weeks. For hearing screening, it's no sooner than 3, no more than 4. So if you're doing both, when do you do it? At the 3-week mark. When do you refer? If they fail a second distance acuity screen, if they repeatedly fail either of the muscle balance tests, if they show any signs or symptoms, or if they fail any other professionally recognized or appropriate screening process. How do you refer the child? Well, you send a letter of referral to the child's parents. It'll tell the parents how to contact the child's preschool or school and how to report the follow-up information to the school. And you need to include a copy of the screening results. Now, there is a form in your booklet that you can photocopy or you can make your own. And it's in both English and Spanish. And that is in page 55. This is an example of how it works or how it looks. Letter of referral. I kind of like or suggest making your own though, so that you have more contact information already pre-put in. So what about follow-up? It's important for schools to know whether the child has seen the primary care provider, and if so, what the findings were. And changes in the child's management may include preferential seating, encouragement of continued medical care, and vision correction, which must be used regularly. In an IEP, that might include like the teacher having a checklist daily to check to see if the kid's wearing their glasses. And you need to keep the record. So you need to keep the record for the acuities from an examination, any disorders they have come up with, what the outcomes and treatments are, what the educational implications are, when the examination is, and the name and address of the primary care provider or other people who did the assessments. So question, when should a screener refer the child to his or her primary care provider? What are all the criteria for that? Now, record keeping and reporting, let's talk about that some. I love his cute little square glasses. My favorite ones are also cute little square glasses. Love these. These are my favorite ones. I've stopped wearing them so much because they tend to want to fog up a little bit more with masks. So I have these nice little half rims. So it's important that you submit or somebody submits the annual reports on hearing and vision screening online, not by paper, online, between January 15th and June 20th of each year. When would I love if you were in charge of a program for it to be submitted? January 15th, because that would have meant you did a good job and all of your results were there and you did it in the fall and everybody has a good spring semester with everything covered. When do most places actually do it? That's more like in the summer. And the information reported is essential to knowing the effectiveness of the screening programs. And facilities must make the screening records available to the Department of State Health Services for inspection upon request. And this is the website where you would report it, and that's how the login looks. And again, the facility has that. You as a random screener don't. Important, the record must be completed and kept by the facility. The documentation of anything must be signed and dated by the individual who conducted the screening, and the facilities must maintain these physical copies of the records for at least 2 years. If you have any questions about this, though, you can contact by this phone number or refer back to your manual for instructions.
Module 5, Reporting Results. Now that you have learned how to conduct a vision screening using eye charts and optional muscle balance tests, it is important that you know how to accurately report your results to the Department of State Health Services. All facilities must submit annual reporting of vision and hearing screening results online at chrstx.dshs.state.tx.us by June 30th of each year. Using the reporting forms provided in the appendix of your manual to record screening results will ensure you have all the necessary information when submitting your report online. As a certified vision screener, you have the opportunity to make a big impact on the lives of children whose vision problems may have otherwise gone unaddressed. Thank you for taking the time to become a certified vision screener. Your commitment to children's healthy vision makes a difference.
Okay, so the current rules are going to be here at this website, but if you provide them with your permanent email address and your permanent physical address, they will send you notifications when they change things. So, which forms do you need to send to Department of State Health Services by June every year? Talk about it a little bit, but there's only one answer. It's kind of a trick question, but hint, hint. So thank you for watching. We'll see you this afternoon. Do be aware that this is my phone number, but obviously I'm not in my office very often, even under non-COVID, because I'm in the back seeing patients or in labs or that sort of thing. You can contact me by email. You can book an appointment for either in-person or virtual at my bookings page. And one of the emails had cell phone numbers. So the final thing that I want you to do to indicate that you've watched this is I need for you to text me at 409-454-2045 your name, So I know you've watched the whole video, and then so I have your cell phone and your name attached in case you need to get a hold of me. Now this is pertinent because what if you need in the building? What if you have some sort of emergency? I literally live in the neighborhood, so if something comes up and people aren't around, you can get a hold of me at, again, 409-454-2045. See you when I next am scheduled to see you.